Welcome to EDRA Insights, where we bring world-class expertise to clinicians in short, practical conversations. My name is Bernardo Alonso, and I will be your host today. Today's episode explores one of the most exciting advances in endodontics, microsurgical endodontics. In this episode, we will discuss how microsurgical techniques are changing the way clinicians preserve natural teeth and improve treatment outcomes. We are honored to be joined by Dr. Arnaldo Castellucci, internationally recognized endodontics educator and author of the great book Microsurgical Endodontics. Dr. Castellucci, welcome to this great podcast.
Thank you, Bernardo. I'm really happy and honored to be here, and I'm ready to answer to all your questions. Just for your information, microsurgical endodontics is one of my favorite topics.
Excellent, Arnaldo. Perfect. So let's start. For many years, teeth with failed root canals treatment were often extracted and replaced with implants. Today, microsurgical endodontics offer new opportunities to save those teeth. So, Dr. Castellucci, what exactly is a microsurgical endodontics?
Okay, let me explain. Let me explain the title. Microsurgical endodontics. Micro because everything is made under the microscope. From local anesthesia, maybe not the microscope, but at least magnification 3.5 in order to avoid a perforating capillary that will start bleeding immediately. Then the incision is made under the microscope, and then all the procedure, including the suture and the removal of the suture. I installed the microscope exactly on September 1995, so now it's a lot of years, and I couldn't imagine doing anything without the microscope. Absolutely. So everything is made under the microscope. That's why micro. And then it's called surgical endodontics and not endodontic surgery. It's not just to play on words, but because it's an endodontic therapy made through a surgical flap. In other words, Professor Schiller, many years ago, he was my mentor, and he told to the students that basically there's no contraindication for endodontic therapy, and all teeth can be treated successfully endodontically if three conditions. One, if they are periodontally sound or if they can make be so. Second, if the foramen or foramina can be sealed, all of them, apical, lateral, everywhere. And the third one, maybe the most important, with or without a surgical approach, which means that the surgical approach is not just surgery to remove the granuloma or the cyst, but is an endodontic surgery to clean, shape, and obturate the root canal. So that's why it's called uh, surgical endo. Is an endodontic surgery not made through a rubber dam, but through a surgical flap. But still, is still part of endodontic treatment and should stay in the hands of the endodontist, not the oral surgeon or maxillofacial surgeons, because they is not their fault. They're innocent, but nobody told them how what is endo and what kind of result we can achieve today. I can tell you that oral surgeon and maxillofacial surgeon, they are my biggest enemies, and I hate. I fight with them every time because they insist the cystic wall must be removed. And this was something that it was told me when I was a student more than 50 years ago. And they're still there. And I'm happy that in my textbook, there's a picture where I intentionally left in place during the surgery in a lower molar. I left in place the cystic wall because I didn't want to scratch the bone and maybe compromise the inferior nerve. So it was intentionally left in place the cystic wall, and at the recall evaluation, perfect healing. So please.
Excellent, excellent, Arnaldo. Um, so, for your perspective, why has it become so important in the modern dentistry?
It is so important because it's a wonderful alternative to extraction and implant. Today, unfortunately, many people, just to save time and to make money, they extract the teeth and put the implant. But what I tell to my patients, especially to women, I say, remember that diamonds are forever. Implants are not forever because we have many complications and they don't last forever. The treated teeth, non surgically or surgically, they can last for the entire life of the patient if the treatment is performed correctly, of course.
But how do long-term outcomes compare between microsurgery and implants?
Well, not only a long-term result is exactly the same, but maybe is even better because implants many times they have complications and they need um, the dentist has to do something, periimplantitis, infection, and so on. Once the tooth is surgically treated with the correct treatment under the microscope, biocompatible material as the retrofilling material, there is no problem at all. I have recall after uh, 20, 30, maybe more years. I'm not sure that an implant can last for so much time. I'm not sure.
Okay, perfect. For the next topic, the role of technology. Well, the technology has transformed endodontics dramatically. How has the surgical microscope changed clinical practice?
It changed completely,
Okay.
upside down. Just to give you an idea, many years ago, when I was attending the meeting at the American Association, United States somewhere, and I was not wearing glasses and I working with my naked eyes, and I was doing everything. And I thought, I can see everything. I don't need anything. I have a very good friend of mine who was my colleague when I was a student at Boston University. And I remember his name is Ian Watson from Toronto, Canada, Mississauga, actually. He said, Arnaldo, listen, um, I want you to try these loops 2.5. I said, I don't have the cash with me. I don't have maybe my credit card. Don't worry. I will pay it for you. And then one day you will give my money back. So I came back with my loops 2.5 and I said, wow, what a big difference. And so for many years, I used the 2.5 loops. But then the light was also another big problem. And finally, um, in 1993, I think, uh, I attended a course with my friend Cliff Radle, and I think was one of the first time I put my eyes on the microscope. 1995, I bought the microscope. I installed the microscope. 1996, I went to San Diego to Gary Carr, my very good friend, to take a course with him how to learn the use of the microscope and how to teach the dental assistant to assist me at the microscope. And since then, uh, I, as a nice present, I gave my dental assistant the assistant scope so she can see exactly what I see. And I don't need to ask for anything because she can understand during surgery what I need. Suction, I don't have to say suction here, do that, because she has a wonderful, perfect view because she's looking exactly what I see. Now, the assistant scope I know is pretty expensive, but it's a good investment. It's not only a present for my dental assistant, but it's an investment for me because my assistant will assist me completely. And it's completely a different world, completely different.
Okay, so which technological advances had the greatest impact on treatment success?
Technological advances, well, first of all, the microscope, I already told you.
Mhm.
Then the ultrasonic. retrotips. So the cavity, the retro cavity during surgery is not made with the straight end piece and the burb, which was never in the long axis of the canal, but with the retrotips still designed and patented and invented by my friend Gary Carr from San Diego. But lately, the the very last technology that I installed now maybe 15 years ago in my office, and again I couldn't live without it, is the CBCT, because this is another thing that changed completely my approach, my life, and my treatment plan. You have no idea how many times I see a B-dimensional X-ray, I have any kind of doubt, and then I said, "Lady, with your permission, I would like to have a 3D image." And now, uh, what it seems maybe a little shadow is a big lesion at the apex of the distal buccal and mesobuccal of the molar. And while the patient was referred to me only for the lesion on the premolar, then I took the CBCT. I saw also the lesion on the other, because in the bidimensional film, it was impossible to see. And this is the big advantage, because we can see many more things and we can plan our treatment plan. Give you an example. The lady has the crown, a post, and need some kind of retreatment in a buccal root of an upper molar. I take the CBCT, and if I see that the palatal canal is okay, doesn't have any lesion, nothing, then I don't start removing the crown, removing the post, and doing a non-surgical retreatment, because it will take a lot of time and a lot of money for the patient with a new crown, new post, new everything. In a 2 hours appointment, maybe less, I do the surgery on the mesobuccal, distal buccal, the case is finished, and the patient leaves the office with the crown perfectly, of course, must be in a good condition, no secondary decay, uh, aesthetically good, and so on. But then the treatment plan, surgery or non-surgical treatment, rather than I decide, and after I take the CBCT many times.
Okay, great. So for the next topic, we are going to talk about common clinical mistakes. Uh, Even experienced clinicians face challenges in microsurgery. What are the most common mistakes you observe?
Well, uh, I don't want to be rude in front of oral surgeon and maxillofacial surgeons, but the biggest mistake I see many times is the surgeon are worried about the cavity in the bone, the lesion. So they remove the lesion, they scratch the bone. And I have big collection of cases where I had to do another surgery because they don't put they didn't put any retroseal. They didn't understand that the problem is not the lesion in the bone and the cystic wall. The problems are bacteria inside the root canal. So during the surgery, without sealing surgically the root canal, it doesn't mean anything. Another mistake still made most of the time by the oral surgeons. I know, I'm sorry, but this is the way it is. And not only in Italy, because I attended the lecture years ago at the American Association meeting, and I attended the lecture from Singun Kim, and he said exactly the same things that I'm telling you now. I don't know why. Oral surgeons and maxillofacial surgeons, nobody told them anything about endo, and so they are still worried about the cavity in the bone, but they forget to put the retroseal. So another mistake, I see that maybe they put the retroseal, but with amalgam, like we used to do 50 years ago, and maybe with the burrs, not with ultrasonic tips. So uh, I always say, why don't you come to our meeting, my dear colleagues, oral surgeon, maxillofacial surgeon, to learn from the endodontic uh, community what we have to do today. And in my textbook, I have several cases, without mentioning the names, of course,
Mhm.
but several cases from my collection of the big mistakes made by the oral surgeon maxillofacial surgeon. Another little mistake can be made. not so difficult to make, uh, is to put the retro prep not with the ultrasonic tip, not in the long axis of the canal, but a little bit deviated. But as long as it is not perforating anything, it's just a little bit out of the axis of the canal. It's just ugly to see on the X-ray, but the healing can come uh, of course the same.
Okay. Which step of the procedure is most often underestimated?
Good question. But in my opinion, there are several steps
Okay.
underestimated, like the flap design. The flap design that I use is the Ocean Lubke design, which is submarginal incision. And many people, and I know many articles in the literature, they say, oh no, this is, forget this flap design because as a terrible consequence, we have terrible scar tissue. I can, one day when I have time, I will publish an article on Journal of Endodontics showing many cases, all of them almost. Without, it depends also on the kind of tissue of the patient. But many times they, like the patient I saw yesterday, I recall the patient after 15 days always to check the healing of the incision. And the patient told me, Doctor, I don't have any scar. Did you really do the surgery to me? I said, yes, but I know how to prevent the scar. Another thing which is underestimated is the use of adrenaline, 1 to 50,000 concentration to control the bleeding. The first secret for to be successful is visibility. Visibility means we need to control perfectly the bleeding. Otherwise, it is a battle between the blood and me, and the winner is also the blood because I don't see anything. So
Yeah.
no anesthesia with the vasoconstriction adrenaline 1 to 50,000 in my hands in my office means sorry, no surgery, because otherwise uh, we don't do the surgery. We do a big mess, which is not what I want to do for sure.
Okay. Perfect. Talking about your great book, Microsurgical Endodontics, well, it has become an important resource for clinicians worldwide. What inspired you to write this book?
Well, it was inspired by my enthusiasm to teach, to transmit exactly. I don't keep any secret for me, and I like to teach and tell exactly what I do in every single day, just for to have fun. Years ago, I had a colleague who came to visit me, working on a patient in my office. At the end of the day, he said, "Dr. Castellucci, I must congratulate because you really do exactly what you say when you teach." I said, "Of course." I can say something and and do something else. I I do exactly what I teach, and so what inspired me is the enthusiasm to transmit and to share my experience. Now I have 46 years of experience after being at Boston University in finishing my program in 1980. So much more experience, of course, after I installed the microscope and everything. But um, I wanted to give all the information possible in the book. And as a matter of fact, inside the book, I put many, about 30 QR codes with video. I like
Okay.
to document everything. When I do any kind of surgery, I start the recording and I close it at the end of the surgery. Then many times I ask the patient, lady, do you want to see what I did on your maxilla? And then they say, oh, no, I don't want to see the bleeding. But then sometimes I give in their hands a very small instrument. Now, this is a pencil, but I give the instrument which is a mirror, okay, 3 millimeters in diameter, which your naked eyes you think is nothing. And then I say, look, this is a mirror. She said, a mirror? I said, then take a look with my recorded video. What I can see through the microscope and through this mirror, 3 millimeters in diameter, I can see everything. So I record everything. I ask the patient if they want to see, but most important, I uh, I decided to put QR codes of video from how to perform anesthesia, how to make the incision, how to make every single step up to the suturing and the removal of the suture. So everything is very well documented, and so um someone can take the book, read the book, watch the QR codes. Maybe if he comes to take a 2 day course in my facility, which I organize 2 or 3 times a year. Just yesterday, I received information by two colleagues from somewhere in Europe. I don't know. They asking for the next date for my surgery course with the workshop. So when I many times as a present to the participant of my course, I give the the textbook. But um, uh, not only I give a lecture, but they also practice on a mannequin, of course. But the mannequin is simulating perfectly the real patient. So they make the incision, the bony creep, the, the cavity, the retrofill, the suture, everything. Then we take an X-ray and then we will discuss. So I have many colleagues from one came from the United States, from France, from different parts of Europe, that after taking the course and having the book, maybe a couple of weeks later, they send me the picture and the radiograph of the very successful surgical treatment. Very, very interesting.
Okay, for the next question, I think you have already partly answered it, Arnaldo, but what, in your own words, what makes this book unique?
Well, if you go to my website and you look at the comments of colleagues after taking my lecture or having the book, more than one guy made a video holding the book in his hands and say, uh, I'm happy to know, to tell everybody that this is the best textbook I ever had in my hands because it explains everything. It's what I said, not only on words and picture, but also on QR codes and video. So, in my opinion, not because it's my book, and not because I was very happy to print it with the editor Edra, who are just wonderful. They didn't put any limit to my material. Okay, they didn't say no more than top pages, not more than top picture. No, no limits. So I put everything I wanted, and I think that this is. I don't pretend to be the only textbook on microsurgical endo, but uh, is made 99% of by one person, me. And so the philosophy, the point of view, the everything is from A to Z, from the same mind of the same person. So there is no contradiction between different authors, like it happens in other textbooks.
Great answer, Arnaldo. And now, for the last part of our interview, we're going to start making rapid fire questions, one word or short answer questions.
Yes,
So, for the first one skill every endodontics should master.
absolutely. Every endodontist should not forget that the last sentence that Archilde said, with or without a surgical approach, which means that the good endodontist must be able not only to do a non-surgical therapy through the rubber dam, but must be familiar with the microsurgical endo, because uh, it can, it is impossible and there are many cases that can be solved only with the surgery, a crown, a post, a lesion. This is perfect. There are many of these cases, and they are very easily, fast, and in a profitable way can be solved with the surgery. Don't call the oral surgeon to your office because he doesn't know anything about endo. This is the problem. So this is where I insist. Every endodontist, okay, must be familiar with the surgical approach. It's part of the endodontic
Okay. One instrument you cannot work without?
therapy. For sure, the microscope. But
Okay.
today I say two instruments, microscope and CBCT.
CBCT. Perfect. One common misconception about root canal surgery?
Yes, the one misconception is uh, difficult. Sometimes it's difficult to deal with the anatomical structure. Many people are afraid of the inferior nerve or the metal nerve, the maxillary sinus, the artery. Honestly, I never was discouraged by the presence very close to the big lesion. I have cases with a big lesion in the area of the first premolar, second premolar and first molar, big cystic lesion, and the metal nerve was right there. Okay, or other cases where the inferior nerve very close. No problem. I know where it is. I know how to avoid the mental nerve, the inferior nerve. So the um, importance anatomical structure very important. There should not be a limit. Same for the maxillary sinus. Many people send me the patient for surgery. They say, "I want you to do the surgery because the tooth is too close or inside the maxillary sinus." And then I say, "So what? The maxillary sinus." I have cases where I had to enter inside the sinus to do my complete surgery, and then perfect healing, no post-operative pain, no bleeding from the nose or nothing. And now the tooth is still in the mouth, so no problem.
Okay. One piece of advice for young clinicians?
Try try to. I need to make some advertising for my textbook and my courses, but try to be familiar, try to fall in love with surgery. When I have a surgical case in my appointment, I know that I am relaxed. I'm going to have fun. I know that I will not have I will not have any surprise. I never had to stop because of I was not able to control the bleeding. Now, let me be honest with you, because in my entire life, two times I had to stop the surgery for anatomic reasons. Unfortunately, these cases are very old cases. At that time, I didn't have the CBCT. Today, with the CBCT, I could know in advance the problem. The problem was that when I was doing surgery in a lower premolar, was a lower second premolar, okay? When I was raising the flap, I realized the unusual emergency of the mental nerve, which was coronal to the apex. So I had to stop because I told the patient, listen, I give you three options. I cut the nerve to reach the apex. She said, no, thank you. I sacrifice half of the root because the apex is too deep down, far away from the nerve. She said, no, thank you. And then the third, I said, I suture and I give you an appointment for a non-surgical retreatment. And so she said, thank you, yes. But only two times. And I have the radiograph, I have everything documented where there was maybe a ramification of the mental nerve, but was coronal to the apex. And I didn't want to cut the nerve because the apex was underneath there. But otherwise, I uh, I never had to have any interruption. I have no um, surprise like in a non-surgical endo. Sometimes the canal is calcified, it's difficult to find, the broken instrument doesn't come out, the canal is blocked, and then I need the next appointment. In surgery, one way or the other, which always is the best way, of course, the case is finished. 1, 2 hours. That's it. No surprise.
Okay. For the last one, Arnaldo, one habit that separates great clinicians from good clinicians.
Well, the great clinicians, it's easy to be good clinician because uh, if you ask to a patient, what do you think about your general dentist? Oh, she says, it's wonderful, wonderful, blah, 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 blah. But maybe it's wonderful because it does extraction without feeling any pain. This is not, it's not good, of course. So the great clinician is updated. He goes to the meeting, read articles, uh, goes to the congresses and read the textbook, and you should be familiar with every single step of non-surgical and surgical endo. This is what's great, that makes them great. And I go around not only to give my lecture, but also to attend somebody else's lecture because there's always something to learn. That's why I go every single year to the American Association of Endodontists. Uh, I was in Prague a few months ago in a congress where I gave a lecture and a workshop about surgery. But together with me, in the other day, I attended the lecture of the two speakers speaking about different topics. They spoke about laser, okay? And it was quite interesting for me because I discovered few things that I didn't know, not only about laser, but about other things. So the day someone thinks that he knows everything and he doesn't have to learn anything, the same day is gone. It's finished.
Okay. Perfect. So, Dr. Castellucci, thank you for joining us and sharing your expertise. Today, we explore how microsurgical endodontics is transforming the way clinicians preserve natural teeth and improve patient outcomes. For those interested in learning more, we highly recommend Microsurgical Endodontics, an essential source for clinicians seeking to master modern endodontic surgery. Thank you for listening to EDRA Insights. Be sure to subscribe for future conversations with leading experts in dentistry and veterinary medicines. See you in the next episode. Dr. Arnaldo Castellucci, thank you very much. Okay, thank you so much, Arnaldo Castellucci. See you in the next episode. Bye bye.
Okay, I'm always available thanks to you and to Edra, of course.